Good afternoon all, and thank you, Sabri, for including me once again in your IC. In the next couple of minutes, let us go through the tarsofrontal sling, sutures, and silicone adjustments over time. So basically, we are spoiled for choice with so many materials available: fascia lata, silicone, polypropylene, polyester suture. We've got marceline mesh, nylon, and Gore-Tex, which is a microporous implant. So basically, gold standard is, and the permanent one is the fascia lata. I'm not going into details of this because we cannot adjust this over time. It cannot be repaired or adjusted because it is permanent. So let us skip this here. The polypropylene sutures are mainly used as a temporary suspension material to prevent amblyopia in children, where we are planning for a second surgery later on, probably with the fascia lata, a later stage. So advantages to this are its low risk of scarring. It can easily be removed. It does not interfere with the future use of autogenous fascia lata. The downside to this is sometimes it cheese wires. The monofilament nature impedes the tissue integration, causing slippage and recurrence. And sometimes there can be exposure and granuloma. So like in this patient that we have, you can see there is a granuloma. He was previously done with the polypropylene suture. You can see that it is exposed and it's pretty easy to remove it. All you have to do is just pull it and cut it. It doesn't integrate into the tissue, so it's easy to remove it. Nylon sutures are also used as a temporary measure. These materials have got same advantages and disadvantages as polypropylene, and it has a high recurrence rate of almost 69%. This was a study conducted by Ben-Guy-Simon et al. In American Journal of Ophthalmology. And they predicted that the mean period of recurrence was 3 months in acute drop and 20 months in the gradual drop. Polyester is another material which many surgeons use again as a temporary measure. So it has got a polyfilament fibers which acts as a scaffold, and the fibrovascular ingrowth happens and reduces the risk of slippage. It's relatively long lasting, and there was a small case series study done with no comparative studies though, and they reported a recurrence rate of relatively very less, almost 0 to 12.5%. So this young girl had got her ptosis surgery done elsewhere with the ethibond suture. So you can see the notching here, and the you can see those marks of the suture track. So this material, however, sometimes causes tissue complication as exposure, infection, and granuloma formation. It may be quite difficult to remove it once it gets integrated into this fibrovascular tissues. You can see that it is a polyfilament, so the tissues go into it. Not only that, they also form a fibrous tract around incorporating the material. So like this girl that I mentioned to you, I had to kind of dissect it out. It was not easy to remove the entire track of the material. And so I could remove it in bits and pieces. Basically, I cut the connection of the pentagon, but she still had some residual lift. That is probably the fibrous tract which was holding the lid up. So again, in this gentleman, he also had a ptosis surgery done elsewhere in childhood, and also had a recurrent ptosis, but that was again the ethibond suture. I could not really go in and remove. The knot had almost slipped down and I couldn't trace where the knot was. So I just cut the connection of the pentagon, and I could not remove it. I left the whole ethibond within the tissues and did a silicone sling. So bilateral silicone sling was done, and he did have a small undercorrection and he wanted that to be repaired. This was the repair adjustment that I did. This was 6 months after his primary procedure. So it's easy to feel for the Watzke sleeve there. The silicone sleeve, you can actually feel for it, and dissection is made over it. And with some amount of blunt dissection, you can feel for the sleeve, and it comes out pretty easily, although there could be some amount of small fibrous tract around it, which can be dissected and removed. And it slips through the fibrous knot, a fibrous tract which is already formed, so you can actually adjust it and see the lift on the table. and tucked in and sutured. So this was him after, this was pre-surgery. This was him after the bilateral silicone, primarily, done for the slippage, and for the repeat surgery. And this was repeated after, and just slight adjustment done. So although this silicone has got good elasticity, so the lid closure would be reasonably adequate. And this gentleman had poor bells, and they had used ethibond suture, probably not a great material for ethibond. So silicone would probably be a better option. So on the whole, silicone rod is easily available and adjustable, gets encased in the fibrous connective tissue and slides through it. It has an advantage as its elasticity and allows adequate lid closure, and can be considered in compromised bells phenomena. So this was at another patient who had had a slippage over time. He had in his childhood done, and this was another patient with a repeat surgery done. And this was, again, this kid had got a surgery done when he was 2 or 3 years old, and when I saw him, he was close to 6. And I couldn't use the same raw silicone. I removed the whole thing. It comes out pretty easily. You just have to pull it out, and made the same incision as the scar. And you can see that it is going in relatively easily without any resistance. It is as good as a virgin case. And I use the same entry and exit point without making any separate stab incision there, as the needle is pretty thick. So check if you have punctured through. And the process is similar as we do as a primary case. So there wouldn't be any difference. Yeah, and from here you go to the apical mid-brow incision and close as usual. So this was him after his repeat surgery. So Alder and Duane, they also showed that the silicone rod sling reduces the usage of artificial tears and lubricating ointments in patients with CPEO. So probably it is a good alternative material, but over time it can recur. So fascia lata is the gold standard. Monofilament suture materials can be used, but of course with slippage, cut through, and granuloma. Polyfilament gets easily integrated into the soft tissue, difficult to explant, and may not interfere with the repeat sling surgeries if left within. So silicone rod is safe, quick, and easy option, and easy to adjust and redo. Thank you.